Very good morning, ladies and gentlemen. It is my great pleasure to welcome you to this World Health Summit workshop on cardiovascular health for the many and the few. Together with Joël Menard, an eminent scholar in the field of cardiovascular science, he is an emeritus professor at the Public Health University of Paris-Descartes. We will be chairing this session. We have a fantastic lineup of speakers with a broad expertise in various areas of public health in the cardiovascular area. My name is Holger Gerhardt. I'm in Berlin at the Max Delbrück Center for Molecular Medicine, also at the Charité and the Berlin Institute of Health. Germany also has various health centers, including one for cardiovascular research, where I'm also a member. We have, as I mentioned, fantastic speakers in this session. 4 speakers. We will start with Karin Sleva, who is the current president of the World Health Federation. She's director of the Hatta Institute for Cardiovascular Research in Cape Town. And this brings fantastic expertise from a country of low and middle income, and particular challenges for cardiovascular disease, as you will hear. We then will hear from Rory Collins, who is Professor of Medicine Epidemiology in Oxford. He's also very active in the UK Biobank project and has a strong expertise looking also at meta-analysis over different studies to look at common mechanisms for prevention and treatment of myocardial infarction, vascular diseases, cancer, and other health issues. We're then delighted to have Anne Ertz, who is the head of the Novartis Foundation. Since January 2013, she's been leading this organization that is committed to catalyzing innovations that transform the health of low-income populations. She will also share with us exciting new work on digital solutions to world health problems, and I'm delighted to hear more about that. And then finally, we'll hear from Gina Portella, who's been working since 2005 with the organization Emergency as an anesthetist and later medical coordinator, building and leading surgical centers for war victims in Afghanistan, building the Salam Center for Cardiac Surgery, and she will share her insights on what can be done as a medical division coordinator at Emergency to oversee and build activities to help populations worldwide, in particular, again, in low and middle income countries. So why the title? Why cardiovascular disease for the many and the few? My personal expertise is in basic science, and working in Berlin together with colleagues at the Charité and various universities and research institutions, we have started a program that is trying to recognize the systems character of cardiovascular diseases, focusing on the organ transcending processes and seeing more and more in detail through deep phenotyping and including even single cell analysis, what the fundamental pathomechanisms are that drive progressive cardiovascular disease. So from this perspective, looking at the various detailed issues as a basic scientist, when Detlef Ganten, the president of the World Health Summit, asked me to organize a workshop, I thought, let's try to focus on the challenges that we have with directing personalized medicine for cardiovascular disease. When I then picked up the phone and was happy to speak to Rory Collins, my whole perspective changed. Talking to somebody who has clinical expertise and looks way beyond my horizon, we realized that personalized medicine might only be really accessible and useful for very few patients. And the problem of cardiovascular disease worldwide is much bigger. And therefore the title, between these two different options, what can we do with more and more directed therapy for individuals? But what is more important is what can we do for the global health issue in cardiovascular disease? We'll start, the introduction is almost over. Joël Menard will continue to get us into the topic, and then we'll first hear from Karen, then Rory, then Anne and Gina. And then we really want to have a lively discussion that will help to moderate, where you can field your questions that I will try to pick up, and we'll have a lively discussion between our speakers. With that, I hand over to Joël.
Thank you very much, Holger. I like to thank you for your invitation because indeed I have a lot of questions in myself. I have nothing really sure to discuss, but since approximately 10 or 20 years, I really wonder where we are going to with cardiovascular diseases. I have the deep feeling that major changes are occurring, but and that probably choices have to be done all over the world, but I really don't know in what direction we should go. I have the privilege to be very old, and this kind of meeting, the first time was in 1983 at the WHO, and you will be interested to know that the two major topics were cardiovascular disease and the Monica Project, and rheumatism, especially in India. So we have spent at this time with Tom Strasser and Dr. Pizza a lot of time to discuss these two issues, rheumatic diseases on the one hand, the cardiovascular disease on the other hand. And finally, today the program is proposing exactly the same 40 years after. So the main question I have in mind, and I am extremely pleased to see what will be your reactions, is the following. Is care going to a simplified view, which will take advantage of the major pharmacological progresses of the last years to provide everywhere, including some rich countries, a medicine which should be simpler? Or, on the contrary, should we try to have a more and more sophisticated medicine, which is frequently called personalized medicine, but personalized is a word which is à la mode. Before we were talking about individualization of treatment. Now we say personalization of treatment. But the two attitudes have not the same consequences. If I take the examples from the literature, we will start with the papers and the theories of Lowe and Wald in London. And we will just have to discuss how to administer a very simplified treatment, which is called the polypill treatment, to everybody, everywhere, without increasing the number of exams or without looking at new targets. So this is an oversimplification of medicine. But at the end, the question is to know what would be the most efficient at the level of populations. The other attitude is to think that we are very poor in prediction and we can improve our ability to make prediction by using new techniques. Some techniques will come from imaging, some other techniques will come from GWAS results and from genetic score, for instance. And at the end, we will add new and new exams in order to target more precisely the treatment that we have at the present time, and maybe the treatment which will be found later on through the individualization of new targets on the human genome. So between the two possibilities, I don't know where we should go. The first one is very restrictive for medicine, in my view. And the second one is very exciting. But on the other hand, where are the priorities? Are the priorities in the cancer field, in immunological field, in neuropsychological diseases, or in viral infections? What is the real priority of cardiovascular disease nowadays, and how to tackle this kind of problems that we have everywhere in the world?
Excellent.
So thank you very much for what you will say, and I am really anxious to know what you think.
Wonderful. And with that, I would like to invite Professor Karen Sliva to share her screen and tell us her story.
So, good morning, everybody. It's really a pleasure giving this talk, and I want to use my next 10 minutes to convince you for the many. I want to start. I had the pleasure of writing a commentary to the Lancet, and the last sentence of the commentary was ended up on the title. It was overcoming non-communicable diseases and injury linked to poverty is not a jest of charity, it's an act of justice. And I want to quickly highlight why I was saying that, and just for segments of this commentary. And I hope you have seen the commission 100,000 deaths each year in people younger than 40 years. And it is important in a certain aspect because we are actually not even counting everybody. If you look at the definition of the Sustainable Development Goals 3.4, which tracks deaths due to cardiovascular disease,
It seems we have lost Karen. That is very unfortunate. Let's give it a few seconds to see whether she rejoins. If not, I suggest that we try to sort out the technical difficulties for Karen in the background whilst we simply move over to the next speaker. Rory, I would like to invite you to share your screen, and we start with your presentation instead.
Karen is back. Karen is back.
Karen is back?
I'm so sorry. I'm not sure why I disappeared. Let me try again.
Glad to have you back.
I think you lost me at this slide, isn't it?
Yes, correct.
Yes. So I was telling that the Commission showed that the burden of non-communicable diseases amongst the world poorest billion leads to 800,000 deaths each year in people younger than 40 years. And that this needs to be expanded because many conditions which are common in low to middle income countries are occurring in people who are younger than 40 or younger than 30 and actually therefore not documented. And I further feel that the framing of non-communicable diseases based on the concept of epidemiological transition is outdated. So we think that cardiovascular disease occurs that you first have risk factors, and certain people with risk factors get coronary artery disease, and that's linked to affluence and urbanization. And I think that is too narrow. So what is actually the global burden of heart failure? So currently it's an undiagnosed condition. It is classified as an intermediate underlying cause of death. And globally, you have worldwide about 37 million cases due to prevalent heart failure recorded, but 85% of heart failure occurs in low to middle income countries. So the pattern of heart failure differs globally, and this is a publication from the World Heart Failure Roadmap on heart failure. I will not go into it, but it shows that just as an example that in Europe you have it's more than 50% of heart failure is due to ischemic heart disease, where, for instance, in Southeast Asia and in Africa is less than 10%. So there's a marked difference what conditions are leading to heart failure. So here you see a slide showing very large heart failure registries. One is the ATIA registry, where there were patients from United States, Asia Pacific. Then the European Heart Failure Registry from Europe, obviously, and CESUS is a sub-Saharan African registry. And you can see what is really very striking, a marked difference in age presentation, where in the European countries, the mean age is 72, where in Africa it's 52. And that is important because in Africa, heart failure often affects the breadwinner generation with implication on the management of the disease, of the cost to society, and other aspects. Again, here you can see that coronary artery disease is more than 50% of the cases in US and Europe. This is much lesser percentages in Africa. Also marked difference in comorbidities as diabetes, atrial fibrillation, and anemia. There are also very specific conditions which leads to heart failure in low to middle income countries. And I want just to show 3 of them. So for instance, trypanosoma cruzi infection is endemic to Latin America. It has a prevalence of per 100,000 inhabitants. It's highest in Bolivia with 6.1%, Argentina 3.6%, Paraguay 2.1%, and also prevalent in other regions, at least initially, to a severe acute phase, usually a type of a fever or myocarditis, but 40 to 45% of the cases get a chronic cardiac involvement where they have certain ECG changes, and late they present with bundle branch block, so it can lead to sudden cardiac death and dilated cardiomyopathy. And you have annually about 40,000 new cases and 12,000 deaths, and most of them are younger people, and so it's a very common and problem in Latin America, but most of us are not associating heart failure or a heart disease with this condition. Another one, and I know we will hear later about rheumatic heart disease, but just as a reminder, some of you will not know that rheumatic heart disease is due to poor housing, overcrowding, a streptococcus throat infection due to molecular mimicry you get in people who have a genetic predisposition. You get pharyngitis, but then a certain percentage of the cases develop acute rheumatic fever. And later on, often, and I'll show you this in my next slide, you get atrial fibrillation, heart failure, and stroke. From our own data in a large cohort, which is called the Heart of Soweto study, we looked in particular at adults presenting with newly diagnosed rheumatic heart disease. So they were not picked up as children. And we found, for instance, a prevalence of 38 cases per 100,000 in the Soweto population of rheumatic heart disease. And 20% of those cases presented with symptoms and signs of heart failure and a poor cardiac function, which is important because even if you operate these patients, it's unlikely that they will gain a normal heart function and have a normal life expectancy. So it's simply picked up too late. And 25% of the cases who presented in adulthood with rheumatic heart disease needed surgery within a year. So it's not a disease you acquire in childhood, but the clinical signs and symptoms are often occurring or picked up later. Another condition which is really not very much on the global radar is peripartum cardiomyopathy. It's a disease which affects young women, peripartum. So obviously the patients are young because they're childbearing age. And I don't have time to go into the pathomechanism, but that is now much better understood due to research we did over the last 20 years. But what is important that it was initially thought that it's mainly a disease occurring in Africa, which is wrong because we have showed with a recently published paper that it's truly a global disease. It has different prevalences, but it's also common in Middle East, India, and other regions. And the maternal mortality within 6 months was 6%, but less than 50% recovered their cardiac function within 6 months, which is obviously terrible. But when you're 25, it's not good enough to barely survive because most of the women will not be able to have a normal life expectancy or even reach the 50s or 60 years of age. So what can we learn from global heart failure from today, and how can we tackle it? Just some example. I think I have shown you that hypertension is globally a very, very common precursor of heart failure, and it actually can be picked up early, it can be managed, and heart failure can be prevented. And prevention is clearly the route to go for in that particular case, but it's important to consider cultural, logistic, and economic factors on the development of preventive and management strategies. The next one, there is clearly a lack of awareness of hypertension and the hypertensive disorders of pregnancy, like preeclampsia, cardiovascular disease, and peripartum women altogether, and it leads to a marked global maternal mortality due to indirect causes. And with this, I mean cardiovascular disease is increasing, is almost as high than the direct causes like postpartum hemorrhage. And also that can be prevented by educating the woman that when you are short of breath in pregnancy, it can be a heart problem. Don't wait, see someone, but this is by education. It can be via short videos, for instance, which we produce, which I show you as an example, or via other modes of awareness creation. Then poor access to healthcare is leading to late diagnosis of the precursors of cardiovascular disease. And I think we should really invest and put more effort in point of care testing facility. So instead of this, the patient has to travel for a long time to a clinic, wait there for some time, for instance, an INR testing, you wait for the results. Sometimes the doctor's left to another clinic. It actually it can be a bedside test. It can be a test a community worker can do in the village or where the patients are living. Poor adherence, that is actually the question, if patients in low to middle income countries are really not taking their medication, if they have their medication. And we want to study that. We actually have started. Here you see a slide. We have just developed a dry blood-spawn testing facility for common heart failure. This is unpublished data for common heart failure medication like beta blockers, ACE inhibitors, and others. And it will allow us to see if patients in certain parts of Africa are taking their medication when it was prescribed, or if they are non-adherents because we didn't manage to convince them that taking their medication on a daily basis is important. So what's the conclusion? So I think, and for global implementation, I mean, first, I think we have to recognize that heart failure has many factors, many causes, and we have to focus in particular on regional factors leading to heart failure. This can happen via the facilitation of national stakeholder discussion through roundtables, better than many more documents and papers. It can be via national scorecards, which are fact sheets where you summarize for policymakers what are the important aspects leading to certain cardiovascular conditions. And then you need to plan and research the evidence. So you need to invest much more in research, in data collection, and exchange the data on a global platform. Thank you very much.
Thank you, Karen, for this inspiring perspective.
Yes, I try to stop my share. Yes.
And we continue, and I would like to invite Rory Collins to share his view and his expertise.
Thank you very much for the opportunity to speak. What I'd like to get across is the idea that perhaps the concept of precision medicine, or if you like, personalized medicine, is not necessarily advantageous for individuals, and that perhaps a more population-based approach would be better, not just for the population, but for each and every individual.
Could you briefly press the presentation button so that we see the full slide?
I'm sorry, I am, and
bottom right hand of your screen.
What are you seeing at the moment? Sorry.
We're just seeing the PowerPoint desktop with all the slides on the left and the main slide in the middle. And if you now go to display settings at the top and swap displays, we're ready to go. Yes, swap. Perfect. Thank you.
Okay, thank you very much. So what I wanted to say was that by focusing on population approaches, I think that we can benefit not only the population, but all patients. So I really want to compare the precision medicine approach or the personalized approach with the population-based strategies. And here is a quote attributed to the comic writer Robert Benchley. There are two types of people in this world, those who divide everything into two and those who don't. And in this case, what I'm saying is those who divide everything into two, treat or don't treat, maybe being over precise. The dividers, these splitters, if you like, have been dominated in the development of treatment guidelines for risk factors, chiefly fixated on somewhat arbitrary classifications and definitions of diagnoses, hypertension, hypercholesterolemia. As a result, there's been undue focus on reducing the levels of the particular risk factor rather than on reducing risk. So here we can see an example from the European Society of Cardiology blood pressure guidelines, where we have categories of optimal, normal, high normal, grade 1, grade 2, grade 3, etc. And these are split into those considered normotensive or hypertensive. Then in many countries, and I give an example at the bottom here of the UK National Institute of Clinical Excellence guidelines, trying to make this even more precise by using ambulatory monitoring to decide whether an individual is above or below this arbitrary line of normotensive or hypertensive. How is this kind of splitting being justified? Well, if you look at the observational epidemiology associating the risk of, in this case, stroke with systolic blood pressure, there's a curvilinear association. And when people look at these lines, they kind of get a feeling that where the red arrow is, that the risk is starting to, if you like, take off, that the curve becomes steeper. And so this point of takeoff has been chosen to divide normotensive and hypertensive. However, if you plot this on a log linear scale, and as we watch the COVID-19 pandemic across the world, we're getting used to exponential or log linear scales being plotted, you see a straight line. And this is not just a statistical piece of trickery. What it's showing is that each difference in blood pressure, the same absolute difference in blood pressure, is associated with the same proportional difference in risk throughout the range of blood pressure. That is, there is no particular point where the curve takes off. So the concept that blood pressure is only important above a particular level is really not supported by the evidence when considered appropriately. And if one looks globally, half of all stroke and coronary artery disease is due to non-optimal blood pressure levels, because blood pressure is associated with risk throughout the range. Half is among people who would not be diagnosed as having hypertension. And as Karen pointed out, a lot is of atherosclerotic disease occurring in younger individuals, with most of the burden occurring in low and middle income countries. So if we really are interested in global cardiovascular disease, we need strategies that work not just for the rich, but for everybody. We also know that not only is blood pressure associated with risk throughout the range, but that lowering blood pressure lowers risk irrespective of the starting level. A paper here from the British Medical Journal 2009 showing that irrespective of your starting level on the left, lowering blood pressure by the same absolute amount produces the same proportional reduction in the risk of both coronary artery disease events and strokes. But not only is the diagnosis complicated, but the treatment strategies that are recommended in many countries, this is from the British Hypertension Society, are also complicated. And these complicated strategies of start with one treatment, then measure the blood pressure, then start with another treatment, then measure the blood pressure, then add another treatment, make it much more difficult on a global scale to get treatment strategies in place that are effective and to maintain compliance. And yet again, if we look at the evidence, we know that a single agent typically reduces blood pressure only modestly, and also that increasing the dose of that agent produces diminishing returns in terms of blood pressure reduction, but increases the side effects associated with that treatment. By contrast, combining treatments, adding a low dose of another agent, produces an almost exactly additive effect, and hence greater cardiovascular benefits, because we also know that the more you lower blood pressure, the more you lower risk, as would be predicted by the observational epidemiology. And so here is a analysis looking at the effect in the white bars of adding a drug from another class to the first drug produces much the same effect, whereas in the black bars, doubling the dose of the same drug produces very little additional reduction in blood pressure, but increases the risk of side effects. So starting with combination of low dose, as Nick Wald points out in this paper, will produce bigger blood pressure reductions and minimize side effects, rather than having a titration strategy, which is of course much more complicated. So we should be focusing on lowering blood pressure rather than how to lower it and avoiding these complicated titration algorithms. In addition, we should remember we're not interested in blood pressure per se, but interested in lowering the levels of risk. And therefore, one should be thinking about, how do I lower an individual's risk by the use of combination risk factor interventions? For example, if somebody is high enough risk to give them a blood pressure lowering agent, then they're high enough risk to be given other effective treatments for lowering their risk. And yet, if we look at what happens in reality, that isn't the case. The focus on single risk factors results in the opportunity to reduce risk further being missed. Here are some recent studies of blood pressure and blood pressure lowering. And you can see that the minority of those individuals were receiving lipid lowering therapy, despite being considered high enough risk to lower their blood pressure. And indeed, if you look at the 2018 European Society of Cardiology and European Society of Hypertension blood pressure management guidelines, in 98 pages on how to control blood pressure, there was only one page on the management of all other cardiovascular risk factors. This is a blinkered view of cardiovascular risk prevention, which is not in the interests of patients. And again, we know that among individuals who have high blood pressure, or indeed those who don't, lowering their blood cholesterol, say with low dose, with generic cheap statin therapy, will lower their risk of cardiovascular events, both coronary disease and stroke. We also know that, as with blood pressure, there is a log linear association between cholesterol and risk of cardiovascular events, of coronary events. And yet again, as with blood pressure, guidelines put in place saying, well, if your cholesterol is in a medium range, then you perhaps shouldn't consider lowering it further. By contrast, the evidence shows that if you lower cholesterol from a high level to a medium level, you lower risk. If you lower it from a medium level to a very low level, the kinds of levels of LDL cholesterol one might see in rural communities or hunter-gatherer communities, you lower risk further. So if you lower LDL by more, you lower risk by more. So in conclusion, what might precision medicine, or as I'd like to dub it, over precision medicine, do? Well, I think it prevents all people from receiving appropriate care. Aiming to be precise may result in treatment actually being withheld from individuals who would benefit from it. For example, not giving statins to people with so-called normal LDL cholesterol when that level is too high from a cardiovascular perspective. That tailoring the treatment of individuals may result in people getting less than optimal treatment, complex blood pressure lowering titration algorithms, when it would be much better to go straight to combination blood pressure treatment. As I've shown you, the focus on single risk factors, this blinkered approach, may result in a failure to reduce an individual's risk as much as is possible. For example, giving treatment to lower blood pressure, but not to lower their LDL cholesterol. So precise population health may well not only benefit more people, but it may also benefit all people more. And I must end with one thing to remind people about, and that is tobacco. Tobacco has not been solved. The tobacco industry is richer than ever, and it will continue to get richer than ever unless we keep on remembering that all they have done is move their sales from the rich countries to the poor countries. And that in the 2010s, 5 to 6 million people died every year around the world because of tobacco. And that will double before 2050, unless we actually focus on getting people to stop smoking and we focus on controlling the tobacco industry. And to put that in context, more people are dying today due to tobacco than COVID-19. Thank you very much.
Thank you very much, Rory, for this inspiring perspective. A lot of food for thought. And with that, we move over to Anne Ertz.
Thank you so much, Holger. And it's a real pleasure to be here today with you. So I will start sharing my screen and talk about exactly what you were talking about, Rory. I think precision population health is exactly what we aim for. Do you see something already?
It's coming up.
Okay. So I'm going to talk about how we aim to improve cardiovascular health in urban populations through our initiatives at the Novartis Foundation. So the Novartis Foundation is independent of our company, Novartis, and we aim to advance digital and data-driven approaches to population health to really improve the health of low-income populations by helping health systems to reimagine themselves from being reactive to becoming proactive, predictive, and potentially even preventative. We come from an era where we focused on legacy programs like eliminating diseases such as malaria and leprosy to now, since a few years, we have been focusing on population health and specifically on cardiovascular population health in urban settings. And why? Well, I don't have to repeat it after these excellent presentations of Rory and Karen. It is simply the leading cause of death in the world, and most of these deaths, 3 out of 4 in fact, happen in low and middle income countries. Hypertension, the prime risk factor for cardiovascular disease, kills 10 million people a year. That's as many as all infectious diseases combined. And then I wanted to stress what Karen was mentioning very clearly in your, or Joelle also in your introduction. Cardiovascular disease or non-communicable diseases as such, but let's keep it on cardiovascular disease, they don't get any global attention on the agenda. Do you know that only 2% of the overseas development aid goes to chronic diseases or non-communicable diseases? 98% goes to the malaria, the TB, and the HIV of the world. So it is really very hard to get it on the attention, and governments around the world struggle with that as well. So why did we then set out to build a multi-sector stakeholder or multi-sector collaboration partnership throughout 3 continents? Because we said if we want to improve the way cardiovascular population health is managed, we'll look at the first and foremost risk factor, high blood pressure, as that is something feasible. It's relatively easy to diagnose and relatively easy to treat, with all the caveats you mentioned, Rory, of the difficult algorithms, obviously. But we wanted to address both the gaps in the health systems and the underlying determinants that would have a much more impact on the population health than only mending the healthcare side only. So we set out to build that partnership together with the tech sector, the food and agriculture sector, the transport sector, urban planners, the civil society, obviously, and the government. The government had to remain in the driver's seat of the whole undertaking, so that they would define what the health priorities are that they want to address. And as a partnership, we would co-design the interventions that could potentially help addressing those priorities. Obviously, people were at the center of the whole initiative. We ran this across the continents, as I said, in 3 demonstration cities, but also, and we had one pioneer example that was in Vietnam, Ho Chi Minh City. And the program or the initiative is running in Dakar, São Paulo, and Ulaanbaatar, 2 capital cities and São Paulo. You see very different sizes of cities, obviously, but remarkably, the prevalence of hypertension at the initiation of this were very similar across the world. About 1 in 3 people across the world is suffering from hypertension, and most of them, obviously, I don't have to tell you, don't know that. So the only difference we saw was obviously in this cardiovascular mortality that is lower in African settings than in the other continents because of the demographics in that continent, obviously. How did we go about this, addressing both the health system gaps and the underlying determinant? We proposed a palette of proven interventions. These are all evidence-based interventions that health system managers or policymakers can choose out. And we called it the cardio strategy. Cardio standing first and foremost for care, where we did exactly what you were describing, Rory, simplifying the algorithms for treatment so that it would become very easy to use for any healthcare professional, but also rolling out online trainings for everybody. We had to reform the health corps in most of these cities on the treatment of high blood pressure for a start, but also convince authorities to change the way it was addressed so that lower skilled staff could provide much of the care instead of having doctors to do everything. The A in cardio stands for increasing access to diagnosis first and foremost, and then to treatment, obviously. And that we increased by optimizing screening for high blood pressure outside the brick and mortars of the hospital. When you walk through hospital wards in Ulaanbaatar or in Ho Chi Minh City, they are all full of stroke patients, completely overburdened. And then the corridors are full of people waiting to get their blood pressure measured or their blood glucose measured, whatever. But people who don't have to be in the hospital, but they are just waiting there to get tested. So we identified that as a major bundling block for access and offered screening opportunities in the shops, in the manicure salons, the barber shops, the post offices, the bus stations, now even in supermarkets, in the pharmacies, obviously, and engaged all these shopkeepers to deliver the right information. But the whole screening was done by digital solutions, by Bluetooth. Results would immediately refer the positively screening patients to the health system so that the health system could get in touch with that person if that person wouldn't present it him or herself at the nearest health station. So there we engaged a lot with those non-traditional health players, and it's tremendously successful. I cannot tell you how easy that went. And for example, in Ho Chi Minh City, this has been rolled out throughout the whole city now that there's blood pressure screening available in all of these outlets. And the Vietnamese government has been now scaling that nationwide as well, working with social enterprises, small businesses, but engaging them in the start of the journey for patients. The R in cardio stands for policy reforms. And obviously there's many proven health policies that we know that all the syntaxes on tobacco, on alcohol, are tremendously successful. Rory, I agree that smoking is still a huge issue, but if we look at the last global disease burden that just came out last weekend, smoking in the world has gone down by 10%. So we have to learn in taking the opportunity to learn from what governments did with introducing the tax on tobacco, because it's not the behavioral change that worked. It is the tax and the legislation that worked, most probably. That's at least also a conclusion from the Global Disease Burden publication. But also there's these huge successes of cities in the US that have banned salt and trans fat from their processed food. We know that is very, very successful. So we advocated for all of these policies in the cities where we are working. And that led to major increases in budgets for primary healthcare. So it helped also to install services for chronic patients, which were mainly absent. The D in cardio stands for digital solutions. So obviously the health information system has to become digital if we want to tap into the potential of data-driven solutions to help policymakers make more adequate decisions. And that is a big, big stumbling block. I'll speak about that a little later. But digital can absolutely be a game changer to empower patients and make patients take more responsibility in the management of their own health. So simple SMSs or text messages for people who cannot read, which is also necessary in many, many settings, can help increase adherence massively. You can provide online CME with digital. Obviously, you provide health providers empowerment through these clinical decision support systems that can be innovated even at the edge with artificial intelligence now, and help triage and other routine undertakings being done by much less skilled health workers, which is really important in areas where there's a huge shortage of skilled health professionals. The I in cardio stands for intersectoral collaboration. As I said, we had to work with the tech, the education sector, the employee associations, the food and agriculture, the mobile broadband providers, the urban planners, all of them together to address this major issue of cardiovascular health in cities across the world. Knowing that Ulaanbaatar, for example, has the highest cardiovascular mortality on earth, after Afghanistan maybe, but they're very similar. And the reason for that is that there's been a massive influx of the nomad population that Mongolians were to the capital city to get better living conditions. But with that came more sedentary lifestyle and less physical activity led to the increase in hypertension and strokes across the city. But also their cultural habits of eating very salty food, having no access to healthy options of food for 9 months a year because it's too cold for fresh vegetables, are all factors that contributed a lot. And the O in cardio is the most important letter probably in this strategy. It is the local ownership. If the local health authorities are not in the driver's seat, the initiative would fail. So it has to be the local authorities who want to do this. When I approached the mayors in the first place in many of those cities and explained what we wanted to set out with them, most of them say, this is exactly what we want to do. Here's our budget. Go ahead. We do this together. And we then set it out and built those interventions together with all stakeholders across the city that had to be involved. Patients were involved as well, obviously, as it's very important to get the end user's voice heard as well. So that was our strategy. And let me show you some of the results, in fact, are quite impressive. Within 1.5 years in a system like Sao Paulo that has a pretty good public health system, Brazil has been focusing on public health, specifically primary health with their family medicine policy. They provide, in Brazil, every patient gets access to free treatment, whatever he or she would need. So the public health system functions pretty well. However, at baseline, what we saw was that not a lot of the patients with high blood pressure did reach that control level for all the reasons we know across the world. In Europe, it's the same. I think we are at 25%. The US and Canada are doing much better with 50% control rates, but Brazil was showing us 17% control rates, where patients have access to pretty good primary healthcare and pretty good access to treatment. Only half of the patients got treated also. That was our findings at the baseline. After only a little bit more than a year, 1.5 years more or less, we were able to triple the blood pressure control rates through all these interventions. Screening in Brazil happened in the football matches, in the Corinthians stadiums. If there's any Brazilians online, you will know what that means. Corinthians is the biggest football club in Brazil. In Sao Paulo, 15 million fans. So screening there during match days, awareness campaigns massively with samba schools during Carnival, all of that led to getting many more people under treatment and almost 60% of people controlled. You can imagine how that translates then into lives saved. So also in Dakar, where we started from a whole other baseline with almost no one under treatment because there were no services for hypertension in this African capital city, pretty representative for many African capital cities in sub-Saharan Africa, I can assure you, as we are expanding in other cities now as well. So no services available, and it took us a little longer to set it up, working through all the blocks the government was facing to get hypertension treatment rolling. We were able to increase blood pressure control rates 8 times too in Dakar. We're still advancing and getting many, many more people under treatment because it's very hard to get them there, as there is simply no system to get them into the health services. And in Ulaanbaatar, we transformed the whole primary healthcare system across the city. Quality of care was a major issue, and we massively managed to address that with all of these interventions, as you saw in the cardio strategy. Then we looked at what the impact is of such an initiative. After a very short time of intervention, we did a business case or a full health economic evaluation where we looked at how many lives could we save and how much cost could we save for the health system on its own. And we saw in Dakar, for example, we can reduce the annual risk of coronary heart disease by 5% in this short time of intervention. We reduced over these 2 years, 20% of all strokes and acute cardiovascular events in the city. And we saved thousands of lives. Now it's true, Rory, we have been addressing only one risk factor and we need to look further, but we had to start with something that was relatively simple. So our next phase now is definitely to look at how can we bring that to the next level and add LDL cholesterol to the whole program and do exactly the same. But we know now what exactly are the interventions that provided the best cost saving, but mainly provided the best population impact. We have those data. We are working on the publication of it. So now we go with that package, that toolkit, which is going to become a website publicly available with all of the tools we developed across this initiative, available open source for every policymaker who wants to use it and build its own better hearts, better cities. But we now want to bring this to the next level and really help health systems to transform from being these reactive care systems waiting for people to present themselves when they have an event or when they have an infection and get sick. We want them to become real health systems, to become proactive, predictive, and even preventative. Very ambitious, but we know that with the use of good data and AI-driven tools, we can achieve cardiovascular population health. But we need, again, new types of partnerships. And that's what we set out to do in our latest partnership that we launched now, a data collaborative, the first global data collaborative for cardiovascular population health. We are building this together with Microsoft and hiring, would I say, or attracting a lot of other global partners. Currently, we are already partnering with Apollo Hospitals in India, which is a major healthcare provider in India and has millions of data of cardiovascular disease, has already worked on those data to build new risk scores that can predict heart attacks and strokes 5 to 7 years in advance, and outperforms the good old Framingham risk scores based on wide Caucasian male data only and not representative for the global population. So the risk score Apollo Hospitals has developed with that machine learning outperforms the Framingham ones by twice, is already validated in the Netherlands. We are now validating it in the data set in Brazil. So these kind of tools is what we aim for with our data collaborative, building new AI-driven tools that can help policymakers globally, not only in high-income countries, but to make more adequate decisions and really transform the way we can address cardiovascular health, because it needs to be transformed. We cannot just hope that we will copy-paste what we have been doing here for many years very successfully, and which increased our life expectancy across the world. We cannot hope in the current world we live in, that where COVID is just a wake-up call that our health systems are unprepared to address all the burdens we have. We cannot hope that that will work. We have to deliver health and care in a very different way across the world. And there, what better opportunity do we have than the fact that we live in a digital era? We have to tap into the potential. And last, let me finish by saying that's exactly what we set out in the frame of our work with the Broadband Commission for Sustainable Development, which is an organization, a UN organization chaired by ITU and UNESCO, where all the major UN agencies sit. So you can see all of our working group members, both on the left side, broadband commissioners, and on the right side, external experts. I'm chairing that working group on health, as the Broadband Commission obviously looks at all sustainable development goals. But that working group looked last year, what are the AI-driven solutions that are already making a massive impact on population health across the world? And I can assure you, we had 300 massively impactful solutions from both low and middle income settings and high income settings, not only from clinical care, but also from population health, R&D, and health optimization, health system optimization. We then distilled that landscape into a roadmap for countries, how they have to advance in their readiness to deploy AI in their health system. How can they create that ecosystem that is needed if they want to tap into the potential of data and AI in their health system? So we built that roadmap, and it came out very beautifully that there are 6 domains that governments have to invest in equally. Equally important, there's no order of importance, but you have to make sure that you advance on each of those equally if you want to really be ready to deploy AI and transform your health system to become that real preventive health system. The first in our people and workforce, obviously across the world, we need to upskill data and digital capabilities, not only in the health workforce, but in the population at large. Maybe Africa has the most digital savvy population, but still there's a big need for data science capabilities. Secondly, data and technology. Let's not forget that even when we speak, half of the world is still unconnected. If we look at what happens with COVID, the digital divide has become the new phase of inequity. So we have to really call upon all governments to massively invest in making sure that their entire populations get access to broadband and get connected. But then at the next phase, governments have to invest in clear data sets, well-architected sets that can be interoperable, instead of investing in 100 different electronic hospital records that don't talk to each other like we are facing in the US and in Europe now. Governance, regulatory, of course, all governance needs to build the systems that keep their people safe and that keep data private. I don't have to repeat that. Design is hugely important, that the end user is involved. Design has to be centered around the person, and processes for integrating AI solutions in health systems have to be thought about before you develop your AI solution, as otherwise you will face with very much resistance in the health workforce, as we saw, and end up with a fragmented landscape, which we saw with the digital technology innovations in Africa, for example, that there were thousands of well-intended digital innovations coming to the field, and governments had no more view on what was happening in their country. So it's really
I'm very sorry. I hate to interrupt you,
okay.
But we would love to have time for questions. It's
okay.
very inspiring.
I'm
if
finished.
you can come to an end, then we can move on to
Thank
Jean.
you, Holger. I thought I was going to go too long. Let me finish by this. So that's the last slide I have, but let me conclude with a similar conclusion like Rory and Karen. As cardiovascular disease is the leading cause of death, we really need urgent action. Get it on the agenda globally is first and foremost priority, but it also calls for innovating the way we handle or we deliver health and care. We cannot continue doing as we are doing currently. And specifically in the era of COVID, we have to build on the momentum that we understand we need to do things differently, to do that also for cardiovascular disease. Specifically because COVID and cardiovascular disease is a syndemic now. So that's what I wanted to say. Thanks a lot, and excuse me for being a bit long.
Thank you so much, Anne. This is super inspiring, and it's great to hear your passion for the project. And I'm sure we will finish with Gina on an equally passionate take. So please, Gina, share your screen, and we look forward to your talk.
Thank you very much to invite me to this presentation among such a good group. I'm trying to share the screen. Let me know if it's visible. Is it working?
Yes, very good. Thank you.
Thank you again very much. And I would like to present an approach that has been our approach in building a center for cardiac surgery in Khartoum in Sudan, and that has been seen as a way like to put perhaps the cart before the horse. Just I would like to give a short presentation who we are. We are an NGO, international organization, and our mandate is, let's say, quite simple in the words. So to provide free of charge, high quality health care to victims of war, poverty, landmines, and to promote a culture of peace and solidarity. What is our view of medicine? We think that a human right-based medicine should be equal, high quality, and should involve social responsibility. This is our big words that would like to summarize that equality means that everybody can have access to a high quality medicine, and means that we will not select what is the level of standards of medicine that should be delivered to each population according to the possible condition there, and also the availability of medium. But we think quality should be the same for everybody. And social responsibility is part of this, means that the governments and authorities should be involved in guarantee the good level of medicine for their citizens. And so that can explain why at some point we decided in 2007 to build a center for cardiac surgery. This slide just shows how is equipped this center and the fact that it is autonomous. We try to have not only good service in terms of surgery, intensive care and so on, but also to be autonomous in terms of which are the ancillary systems that are needed to manage an hospital, and an hospital that guarantee a comprehensive treatment for the patients. The building of this project has been agreed among many health authorities in Africa. So we are working still now with them to build in Africa a medicine of high standard thought as a network or center of excellence that can provide for people in low-income countries access to a medicine that usually we don't think is so needed in those areas. Why? Because we most of the time think about basic medicine or more attention towards communicable disease. So what we face at the beginning when we started to work with this center, well, for me as a doctor, was a real surprise to find out that perhaps because we were offering this service for free of charge, we start to face a disease that for me was not well known. I'm talking as really as a doctor, as a health provider. And we know this disease, I'm talking about rheumatic heart disease, unfortunately was very common and was one of the leading causes of death back in 1920s in our countries. After that, we know that has been basically eradicated in Western countries. I'm sure that all the audience is very familiar with this study that has been published in 2017 that is showing how in yellow color are the endemic areas with the rheumatic heart disease, how Western countries are basically out of the problem. Instead, still millions of people are affected and there are still a lot of death all over the world and mainly in low-income countries. To face this problem, the picture on the right is showing how many cardiac surgeons can be available for such a huge amount of population. So let's say, starting that project, we find out that there was a big problem, and the cardiovascular disease is perhaps a problem different from what we think only in our countries. Of course, the condition of the areas that we saw before in the map are those that have all the risk factors to develop the rheumatic heart disease. And unfortunately, we know that once symptomatic, cardiac surgery becomes the only life-saving option for many people. And we can see that 900 million people on sub-Saharan Africa have access only on 22 cardiac centers. And unfortunately, I have to say that I'm not sure that they are free of charge. So to offer an approach like our approach to build a cardiac surgery center with a good standard of treatment seems a lot like to put really a cart before the horse. But what we realize is that we were able, working really together with the authorities, the health authorities and the other doctors in the other countries, to build a regional program. So to offer the opportunity to have this kind of treatment, not only for the population of Sudan and the Khartoum area, but really to offer a service that can be a benefit for people coming now from more than 30 different countries. And this is just to quickly show, which are our population, which kind of patient we saw. The more dark green are the patients with rheumatic heart disease, and the lighter green are mainly congenital heart disease. So not surprised, I think, from what we heard, to see that most of the population that we have been treated on this is exposing the data of 10 years of activity, is affected by rheumatic heart disease. And mainly what is a surprise, not a surprise, but let's say something that is very challenging, is that acquired disease, as rheumatic heart disease, is affecting a lot also children under 15 years. Here you see basically which are the number of patients operated. As you can see, more than almost 80% were affected by rheumatic heart disease, but also congenital heart disease is highly represented. Unfortunately, it's very difficult to find congenital cardiac surgeon willing to come and spend a long time in a country like in Africa, Sudan. And so the program is a little bit not continuous, let's say, for this case, but it is continuous for rheumatic. And this is just to share with you which are the population, some characteristics. So we can see that the mean age for children under 14 is very low, but is low not only for the congenital group, but also for the rheumatic heart disease. I have to say that is impressive that sometimes we have to do surgery for children that are 6 years old and they need the replacement of 2 valves plus some adjustment for tricuspid valve. And also what is impressive, what is another challenge, another, let's say, field of study also, is the fact that due to the cardiac disease, but due probably also on the condition, the patients are very malnourished. And this put different, really challenge how to treat those patients. What we study in our countries to deal with patients with cardiovascular disease and the risk factors are totally different for this group of patients. This is just to show you that, of course, we are able to evaluate our job in terms of early mortality, and we can see that actually the results are feasible, are comparable, if not even good, I can say, in terms of early mortality. But what is interesting, I think, in countries like Africa, and talking also about a regional program, is the ability, the possibility to follow up the patients. If not really, this become a nice exercise of technical practice and not any benefit for the patient. So as you can see here, the overall follow-up is much better, of course, for rheumatic heart disease, also because those are patients that keep needing therapy, long life therapy, and also this we are offering free of charge. But what is very important is that we follow them. We try a comprehensive approach that means also counseling and teaching about which are their risk factors and how they have to take care of their own health. This is again is just to show that they make sense to do that, because also when we talk about rheumatic heart disease, of course we know that the surgical approach is a late approach, means that the patient that needs surgery, of course, at the course of the disease, and the situation for them is just the only solution, let's say, can be surgery. And so, but what then? I mean, are we offering just an option with the short surviving and perhaps just an operation and nothing else? Let's say this graph is showing that it's possible. It's possible to do that and follow up people that have low socio-economic level, and that many times, unfortunately, means that also they have low level of education, and they really cannot perhaps approach their own health in the proper way. So this can be something that can encourage and move on. So after all this work, we find out that in Africa, the African doctors, the African health authorities are really looking for eradication of rheumatic heart disease. This is well known, I think, communique of the Addis Ababa in 2015, where 7 points are being considered are the key points to reach the eradication of rheumatic heart disease. Of course, cannot be only one single approach that make it, but we saw that the African community, and I don't know how much the international community, but I hope so, are very aware that beside prevention and other things also are needed still, unfortunately, Center of Excellence for Cardiac Surgery that not only will treat the people, but also can train next generation of cardiac practitioner. And this not only in such a specific field like surgery, but we are talking about cardiologists We are talking about general practitioner able to work then in most rural area, so to be able to prevent or intercept earlier the disease and avoid to reach the level of surgery. And so, of course, this is a project, is a seed, is something that has shown some strength and some weakness, of course. Strength is that it's possible to do that, can offer continuity of treatment, continuity of access for the people, can be done with high quality, can start to enlighten a comprehensive approach, can offer the opportunity of capacity building and also opportunity for research. The previous speaker underlined a lot the point of research, and we are totally on this line. Of course, the weakness is that if we remain a standalone project, apparently, or let's say on practical issue, of course, this is a seed in terms of efficacy comparing to the needs. And another issue that must be, I think, addressed is that we find out working on this practical issue that is very difficult to retain next generation of African medical professionals. And this doesn't matter which is the field that we are talking about, but should be one key point to follow. And so also I will present, of course, a slide about what we learn, and we learned that free of charge specialized surgery is feasible, unfortunately still very necessary, and can also help this kind of approach to shed light on yet endemic disease that are neglected, I think, also from scientific community. The knowledge about rheumatic heart disease is still at the low level. And yes, I'm finished. And so we would like to say that we are fully aware that eradication is primary and secondary prevention, but we advocate what we all did, I think, a fruitful collaboration that will comprehend all the international scientific community, organization, governments, institutions, and so on. Thank you very much, and sorry to be long.
Thank you very much, Gina. Thank you all of the speakers for these extremely insightful, very broad, inspiring, and in part provocative lectures. We wanted originally to be all in one room and have a roundtable discussion with the audience. Thanks to COVID, this doesn't work. I haven't seen any questions yet, but whilst they are coming in from the audience, maybe we can start discussing what we started out with Rory's lecture on risk factors versus actual risk. It's absolutely mind-boggling that this problem persists, because the way you put it, it seems so obvious. What is the reason that we're not making any progress in dealing with this? Maybe all the experts can sort of chip in and share their views on this. Karen.
Can I perhaps ask something? I wonder, Rory, if our risk is actually not starting much earlier. I mean, if you look, we are 7 billion people, and I think virtually everyone who's born now has some risk. I mean, we are simply, most of us live in urban areas. Most of us eat processed food. If there is now, if you can not, you know, many can't afford, many don't know. Most of us don't move enough. So if you actually, this whole risk factor concept is really a bit outdated, because we have changed so much. But I think the risk really start, we know, either preconception or basically in utero. It's clearly there from the beginning based on your social circumstances. For I really would estimate at least 80% of the global population. So I really share your sentiments that we have to restructure our concept about risk factors. And we start much too late. If you have coronary artery disease, if your blood pressure is high, if your cholesterol, I don't want to go to the entire pathophysiology, but obviously the damage is done to a very large extent, not even talking about your brain factors, cognitive decline, and all the other components. Yeah.
Yeah, Holger, if I may, I would like to add, it's so true
Please.
that it starts so much younger. We've seen in a specific study in school children in Port Elizabeth in your country, Karen, where we worked with the University of Nelson Mandela and the University of Basel here. And we saw that in children under 12, already 23% of them had high blood pressure. And their cardiovascular parameters are really scary. And the reason is that one of the reasons is obviously the food, but also the physical exercise. There was little physical exercise in the schools, no possibility to do sports because in the most underserved schools, there were no sport facilities. So we introduced dance, really very active dance like we would do in the fitness Zumba. And kids and teachers, both were included in the program. They both loved it. And with that, we managed to reduce their cardiovascular risk factors, and we got their cognitive performance much better as well. But also their fitness level was absolutely corresponding to how much we would have the dance lessons on the ground. And it's a real important finding, also available with all the tools we have for all the schools. Now we try to make that a national program in South Africa, but it takes a while, but it's really scary. It hasn't been described, I believe, in African children so young.
Excellent. I have a question here from the audience, from Karen Sipitu. She says, importance of cardiovascular disease is clear, yet less uptake in research and the pipeline of innovation is a problem. What are the mechanisms in setting health research priorities? And I guess this is beyond low and middle income countries. She directed it to the panel. Maybe Rory, you want to answer?
Well, I think one of the most important things to remember, and I think Anne brought this out, the other speakers as well, is that 95% of the world is not American. And that a lot of the strategies are as if we're in America. So we forget, as I tried to indicate, that tobacco remains a major problem. We forget that rheumatic heart disease remains a major problem, and so on and so forth. When we talk about treatments, I think the possible is prevented by the pursuit of the perfect. I mean, frankly, to deal with cardiovascular disease on a global scale, we don't actually need more innovation. We need to do what we already know to do. And as Anne pointed out, that things that are done at a population level, particularly tax, fantastically effective at reducing tobacco consumption. And as Richard Doll used to say, the tobacco industry employ the smartest people in the world. So the key thing is to find out what they don't want you to do and then do it. Tax, they don't want you to do, so do it. Plain packaging on cigarette packets, they don't want you to do, so do it. And I think the point that was made just now, this is happening in childhood, and we need preventive strategies that deal early on with the risk factors of smoking, of obesity, of blood pressure associated with salt intake. Again, we don't have any really serious interventions on salt or indeed on sugar around the world. These are the things that will make a difference on global health, not the idea that we need a new treatment. When we look at the treatment of heart attacks, you go to any congress in the world and it will all be about primary angioplasty and stenting. And yet we know the vast majority of patients who get heart attacks will never get that treatment. They get the old Viet Cong, if you like, treatments of thrombolysis, and yet no one talks about it. Forget America. Think about the other 95% of the world.
Yes, I need to interject here because this is so provocative, and it's certainly true. But our title also says for the many and the few. So it's not going to be enough if you have a patient in a highly equipped hospital in America or in Germany or any high-income country to say, well, we've stopped research, we're no longer interested in pathomechanisms because we should be spending our money elsewhere. And some of our audience are with the pipette at the bench, working to understand in detail deep phenotyping, what's actually going on, looking to move into translation, to move their discoveries into treatment options. So if we speak to policy makers and the funders, from your perspective, how does it go together? How do we do both? Or
is the life of an American worth more than the life of 100 Africans?
Certainly not.
Well, why then do we have this focus?
Karen, you wanted to answer
Yes,
something.
no. I really, look, I'm the director of a basic translation science institute, so I strongly believe that you have to do both. But it can go in parallel, and I think you simply have to, and obviously for basic science, translating into something takes a while. So you need to continue with basic science, and you not immediately will have often a result which you can translate into something. But I mean, we couldn't work towards a COVID vaccine, for instance, if we wouldn't have done all the other steps before. So you have to do both. But I think we need to come to a solution where both can happen in parallel. I think that's what needs to happen. And also, I think what Rory is not mentioning, in the US, it's a certain part of a population who have access to primary stenting, and a very large part is not. And you have the same in many parts of the world. If you, even in Germany, where I'm now in the moment, if you live in a more rural place, you don't have the exactly same aspects than you live in the middle of Berlin. These are the realities in most parts of the world.
Correct. I'd like to have a few more, we only have a few more minutes. Michael Gotthard asks to Anne Ertz. He loves the AI for Better Hearts data initiative. How do you regulate access, facilitate data sharing? Do you include existing initiatives such as the Helmholtz cohort in Germany? Maybe a short answer.
Yes, we are just starting that, and that's definitely all the very difficult questions, how to regulate the data sharing and all that. We are working on setting up that governance. Currently, we are sharing with a few organizations, but we want to build that much larger, and it will become like a streamlined governance, which is difficult between private and public sector. But the output of this data collaborative will always have to be open source. That's the condition sine qua non. And I definitely would love to get in touch with existing initiatives, and we are getting in touch, but mainly in low and middle income settings. If there are interesting initiatives who want to share data in such a collaborative from high income countries, I'm very welcome to bring that. But if I may, I would like to say just one positive thing on the previous question. I think, of course, there's always need for more research to understand it better, because we still don't know most of the problems in it. But I think if there's one field in medicine that made a big advance in the past half century, it's cardiovascular medicine. So we have to be very proud of the advances it made and how it increased life expectancy around the world.
Thanks.
So
Thanks for this.
Rory, we need to innovate the delivery, not deliver more innovations first.
Very good. We have many more hands raised, but I would love to have one more question, because then our time is actually over. We had so much. Patrick Wilson is asking, what would panelists recommend as the best buy low-cost preventative intervention for cardiovascular disease in low and middle income countries? So this is cost effectiveness question.
I take 1 second. Education. End of my
very good. Gina, you wanted to say something.
Yes, I would like to say that for me is research something that should be implemented. Because, for example, for this disease, I agree, in cardiovascular disease, we've made many progress, but as Rory said, is for Americans or for Germans or for Italian. The other cardiovascular disease are neglected. So why not to start to consider that all what we learn, all the instruments that we already have will be put on this research. For example, why we still don't have a vaccination for rheumatic heart disease? is a huge problem. And
Yep.
nobody's talking about it, or when you talk with specialists, they don't have yet a solution. And this can be, something to think about.
Very good. So officially our time is over. Can I ask our organizer, Peshka, whether there's a breakout room if people want to still speak with the speakers, or do I have to close now? Peshka? Well, sorry?
Was denn? No, it's all the speakers can answer the questions per mail.
Okay, but we have to close our session now.
Yes, we have to close. Only 2 or 3 minutes to go, but then we have to close, yes.
Okay.
Good.
Very good. Well, in that case, if we just got another 2 minutes added, that's great. Is there, the questions that we had fielded here have been answered. Did I rudely interrupt something else that one of our panelists wanted to say? If not, this was for me, coming from the basic side, a real eye-opener. I hope for many of the audience as well. And I very much hope that we can engage in more discussions. I've had in the coming up to this workshop some exciting discussions with many of you, and see where our efforts in research and policy making and putting more money into cardiovascular disease research as well as prevention can go, and what we can achieve together. So I'd like to close with thanking again the speakers for their fascinating presentations, all the audience for their questions, and stay healthy, and hopefully we'll make progress. Thank you.